Good afternoon, everybody. So today we're going to be dealing with a branch of prosthodontics which involves the fixed aspect. So that when we say general considerations of fixed prosthodontics, we are mainly talking about crowns and bridges with respect to the clinical scenarios, your post-core treatment plans, as well with the twist. So earlier, your need-based questions mainly used to resolve upon the types of pontics, your connectors, the post-core systems, and everything as such. However, the following scenarios, what we're going to deal with is basically with respect to the cements, the different types of treatment protocols that might be followed, as well as the different types of case-based studies. So when we get right into it, that is what the general consideration is going to be about. So coming to the first question, that is with respect to the porcelain failure with respect to an all porcelain crown. So the question goes, porcelain failure, how can it be best avoided in the cases of your all porcelain crowns? Is it when the occlusal forces are minimal, when the ceramic material is not over half a millimeter in thickness, the ceramic material is 1.5 millimeter in thickness, or the angles of preparations are rounded? So ideally, when we answer a question like this, we have to understand why a porcelain failure is actually occurring in such crowns. So ideally, it could be either because of the material not being thick enough, or it could be because of the too many forces acting upon a particular area, or when the angles of the preparation, that is your preparation itself, is at fault. So whenever we have a fix, whether the type of crowns that we are going to be involving it, whether we decide on the force, whether it's about thickness or the preparation, how do we actually decide the type of failure? So ideally speaking, we first have to understand the type of crowns we're dealing with. So I have a lot of people have a lot of confusion with respect to the type of crowns. So what you have to understand with respect to this is that this is with respect to a full metal crown. This is what a full metal crown looks like. And do not ever confuse this with something called a PFM based crown. A full metal crown mainly consists of your nickel, molybdenum, or cobalt chromium, whereas your porcelain fused to metal crown consists of a metal with at least zero point 0.5 millimeters of ceramic, which is layered on top of a metal core. That is the biggest difference between a metal and a PFM crown. The core remains the same, that is the metal core, whereas the layering, which is on top of it, is mainly the presence of ceramic. Also, what I want to understand is the difference between a zirconia and an all porcelain. So even a zirconia crown is a type of an all ceramic crown. This is a metal free base crown. All right. So what you have to understand with respect to this is that a ceramic consists of different types of fillers. It could be in the form of alumina, silica, it could be lucite, lithia, whatever type of base to the core of a ceramic. When one of the major ingredients is alumina, then those crowns are referred to as your zirconia crowns. So whenever an all ceramic or an all porcelain crown is being talked about, do not blindly think that they're talking about a zirconia. A zirconia is considered as an all ceramic only when a alumina based filler is involved in that. Okay, so do not confuse yourself in respect to your need based questions. If it consists of example, lithium disulfide consists of lithia base. It's called as an Emax crown. Okay, so do not confuse with respect to your types of crowns. Also, this one is not a PFM crown. This is a ceramic faced full metal crown. Okay, so you can see the facing of a ceramic is only on one aspect of this preparation. So this is a ceramic based crown, which is a full metal. So I do not want all of you to confuse with yourselves with respect to the types of crowns, whether it be full metal, a PFM, a zirconia, an all ceramic, or a ceramic based metal crowns. Also coming to the types of preparation designs, it's different for all three preparations. Okay, so there have been questions with respect to the regards to the types of preparation, the finish lines, the amount of preparation you have to understand. So I just want you to keep this type of photo imprinted in your minds. So whenever I'm talking about metal, just understand that the finish line is always a chamfer. Whenever I'm talking about a PFM, it has a combination of a shoulder on the buccal or labial side and a chamfer on the lingual or palatal side. When I'm talking about an all ceramic, it is shoulder all around. So based upon the type of crown that is going to be fabricated, your tooth preparation is also going to change. Your finish lines are also going to change. As you can see, a metal does not require so much amount of preparation, right? A PFM requires a slightly more. So a metal is probably 1 to 1.5 millimeters. A PFM is about 1.5 to 2 millimeters. And all ceramic, as you can see, based upon the size of the all ceramic crown, requires a reduction of about 2 to 2.5 millimeters. So this is with regards to the tooth preparation. We'll go in detail with respect to different classes a little bit later on upon the types of tooth preparations and the fundamentals that are involved with respect to the tooth preparation. For now, this is the basic. The difference between a metal crown, a PFM, and all ceramic with regards to the preparation as well as the types of finish lines that are required. So this is what the question was based upon. This is very common with respect to your all porcelain crowns. What happens here is that a small crack is generated and that crack propagates through the ceramic material. So what we have to understand with regards to an all porcelain is that all three factors could play a major role. The first being the thickness of the porcelain, the second being under preparation, and the third being it is not rounded at the finish lines or at the line angles. What happens is that when you leave your tooth preparation nice and sharp, the ceramist is not able to put a large amount or put a large bulk of porcelain in that particular area. So that porcelain, as you know, is a very fragile material, just like glass. So if you have increased bulk of the porcelain, that much more strength is present. Okay, it becomes more stronger. So you put a sharp line angle in your preparation, or the ceramist puts a very minimal amount of thickness of porcelain, it will definitely chip or crack. So that is what has to be kept in mind. Three factors. The first factor is the amount of ceramic thickness. The second is the under preparation of your tooth. And third one is sharp line angles, that the line angles are not rounded. All these factors result in a failure with respect to your porcelain. So this is how an ideal preparation supposed to look like, not like this with sharp line angles. So when you have a sharp 90-degree angle over here, the ceramic over this is going to be very thin. Okay, so when the ceramic over this is very thin, what happens is that it becomes very sharp and the patient bites, it causes a crack or a chip in that particular area, resulting in a fracture of your porcelain. So it has to be nice and blunted. As we see over here, it should be rounded on all aspects. Okay, so this is, and your finish lines also should be clear and distinct to be easily able to seat a crown, whether irrespective of whether it's a PFM or an all ceramic or a zirconia or an Emax crown, irrespective of that, the finish lines and the tooth preparation should be very well rounded, giving us the opportunity to fabricate very good crowns. So coming back to the question that was asked with regards to the failure, the fourth option, the D option, that is your angles of preparation are rounded. This is the best way. If your B or C option suggested that increasing the thickness of the ceramic, that would have also been a good option. Occlusal forces you cannot minimalize because the bite is going to remain the same. However, if you can reduce the high points that are common with respect, if you do not give enough clearance, the high points are very common, that would result also in a fracture of your porcelain crowns. So the answer for this one is D. I see some of you got it right. That is, angles of preparations are rounded. Coming to the next question. The greatest potential for wear exists between a tooth and a metal, a tooth and a tooth, a porcelain and a tooth, or a porcelain and a porcelain. What you have to understand with regards to this is that porcelain is always more stronger than the tooth. Okay, porcelain always is stronger than the tooth. Also, the porcelain is stronger under something called compression. Okay, so whenever a compressive stress acts on the porcelain, it is able to take the wear that much more better compared to that of a tooth. But what has to be kept in mind when answering these questions is that the abrasive factor of a porcelain is much more than that of a natural tooth. So whenever we give an zirconia crown or an all ceramic crown opposing a natural tooth, what happens is that the opposing tooth wears off. Okay, the opposing tooth always wears off whenever a tooth is opposing a zirconia crown. So the problem is that ideally what we give is we give a tooth versus a metal or a porcelain versus a porcelain, not to wear off the good natural tooth. So the greatest potential for wear exists normally between a porcelain and a tooth. That is where it is most common. So whenever a clinical scenario based question arises, which is a better option, a metal versus a tooth, a PFM versus a tooth, a porcelain or a zirconia versus a tooth, the option A is always better. That is, a metal is always safer or comfortable with regards to a tooth structure. But if you want to give a better strength, better acceptance to the patient, then porcelain is always better. So that's where you make a call. These questions are twisted in different ways and asked. So you have to understand how to think. So this question was pretty straightforward. The greatest potential for wear. Whenever questions are being asked with regards to which is more comfortable for the patient, which is more destructive for the tooth, you have to answer it in a much better fashion. Coming to the next question, right? Which of the following is the best reason for pouring a condensation impression material as soon as possible? Is it the degree of polymerization of a condensation material? Is it the evaporation of a volatile byproduct causing a shrinkage of the material? If left unpoured, does a condensation impression material expand by absorbing water? Or does it start to react with the polymers of the impression tray when a tray adhesive isn't used and causes distortion? So, what do you think is the correct answer? So we all know about something called silicons, right? Whenever we're talking about condensation impression material, we're normally talking about condensation silicon. We have hydrocolloids and we have silicons. Your hydrocolloids will be your agar and your alginate, whereas your silicons basically involves your polysulfides, your addition condensation silicon, and your polyether. All right. So whenever we're talking about condensation silicon, you have to understand the composition of all four of them: your polysulfide, your addition, your condensation silicons, and your polyether. So only when you know the composition of such impression materials will help you give and answer such questions. There are a lot of questions, by the way, on dental materials with respect to the composition, with respect to the advantages, disadvantages of each material. Okay, so what I would actually advise all of you is to have something like a chart like this, which will help you know what is the classification mainly of your impression materials. Coming to your non-elastic, we have something called the plaster, your impression compounds, which you've already used in your BDS days, along with your zinc oxide eugenol. And we have something called the elastic-based impression materials. That is your hydrocolloids and your elastomers. So hydrocolloids, we all know about agar, we all know about alginate. The questions have been reduced over the years. Now they are concentrating more about elastomers. So elastomers, do not confuse the consistency of an elastomer with the type of an elastomer. We have something called light body, heavy body, medium body, and putty. That is a composition. That is a different forms of your impression material. Whenever we are talking about elastomers, we are normally talking about polysulfides, polyether, condensation silicon, addition silicon. So ideally, the best among all these impression materials are your polyether and your addition silicon. There are certain disadvantages with regards to your polysulfides and a condensation silicons, but there are aspects in which they are complementary. this is also called into consideration, which we have to use your polysulfides in condensation. Most of the times, your polyether addition silicon gets the job done. So if you're asked a question based regards which is the best impression material or which gives you a better handling characteristics, it's with regards to your either polyether or your additional silicon. Now, coming back to the earlier question, that is with regards to the best reason for pouring a condensation impression material. As you all know, elastomers can be poured for a long period of time. Your addition silicons and your polyether can even be poured for up to 48 hours. That is up to 2 days without any kind of problem occurring within the impression material. Your hydrocolloids, that is your agar and your alginate, do not give you that luxury of being able to be poured. So you know something called syneresis and imbibition, right? So they can cause the removal of water from the impression material and can result in shrinkage or expansion of a material. Now, the biggest problem with the condensation impression material is that it has a volatile byproduct, right? When you read about the composition, which is why I said the composition is so much more important, you have to know the composition. So I see an answer that says D, that it starts to react with the polymers of the impression tray when tray adhesive. It is not true. Actually, the condensation polymers do not technically react with the tray. That is not the reason for a thing. A tray adhesive is basically used to keep your elastomeric impression material within the tray itself. So what happens is that your alginate gets locked within the perforations of your impression tray. Your impression material with your condensation addition do not get locked, okay, which is why we use a tray adhesive, which is like a feviquick for your impression material. You apply a layer of tray adhesive and then you apply your impression material on top of the tray. So the biggest drawback of a condensation impression material is the evaporation of a volatile byproduct. So what happens is that the byproduct within your condensation impression material evaporates, and within a matter of 2 to 3 hours, your material will shrink. So what finish line you have taken, what finish line you have recorded with respect to your impression material will get voids, or it will reduce in size, and the crown which is being fabricated will not fit. Okay, so that is the biggest drawback with regards to your condensation impression material. It is the evaporation of your volatile byproduct. So do not confuse yourself with the other three options. They're just to confuse you, and this is how NEET definitely does it. You have to know the composition, and it will help you to answer such questions more better, with irrespective of the type of elastomeric impression material that is being talked about. Coming to the next question. In constructing a full metal crown, future inflammation of the gingival tissue can be prevented by narrowing of the occlusal table by 1/3, accurately reproducing the tooth form in the gingival third, slightly under contouring the tooth form in the gingival third, or slightly over contouring the tooth form in the gingival third. Now, just imagine a question like this, right? So they're asking you if there's a tooth preparation. So you can just imagine a tooth preparation. Now the question is limited to your gingival tissue, so gingival third. So the question is, can we narrow the occlusal table by 1/3? So we can just reduce this, or do we make it in the same form like how it exists, or do we push this slightly more inside in the gingival third, or do we over contour it? So we prepare more and not prepare less with respect to the gingival third. So these are your four options. How do we prevent a future inflammation of your gingival tissue? So you have to understand your crown is going to rest on your finish lines to an extent. Your periodontium also plays a factor. So that is your fifth principle and your tooth preparation is your preservation of your periodontium. So how do I go about preserving my periodontium? All right. So with regards to this, you have to understand is that whatever tooth preparation you're doing, your tooth preparation should be exactly similar to your actual tooth. Only thing is that it should be in a reduced size compared to what it was. When you're doing a tooth preparation, all you're doing is making space for the crown so that a crown can sit in the exact area. So you do not have to either under contour or over contour. I see one of you have got it right. Very good. You don't have to either under contour or over contour your tooth preparation. It can remain exactly the same. The only thing you have to do is not push your burr into the periodontium or not give it too subgingival as possible. When you go subgingivally, you are going to hurt the periodontium across your finish line. Okay, that should not happen. So the best way to reduce inflammation is by not entering into the periodontium and by reproducing the tooth preparation as similar to the original as possible. So when we come across the options, it is B. You've got it right. Very good. That is accurately reproducing the tooth form in the gingival third exactly like how it was before. We are not supposed to either reduce the occlusal table or under and over contour. I hope it's clear so far for all of you. I hope you don't have any doubts with regards to the questions what we have discussed so far. Okay. Now, going to the next question, more of dental materials, right? So ideally, questions nowadays about polycarboxylate, phosphate are pretty less. They have now evolved to the resin-based cements. Okay. So ideally, I still discuss slightly about the basics. The question goes, when cementing a fixed prosthesis, which of these cements will produce the smallest post-cementation marginal opening? Is it your polycarboxylate? Is it your zinc phosphate? Is it resin cements? Or is it glass ionomer cements? Which of the following will not produce or will produce the smallest post cementation opening? Marginal opening is also referred to as something called marginal discrepancy. Okay. So when you're talking about marginal discrepancy, what you do not want is that as we are in an oral environment, saliva, water, everything is going to enter your crown if there is a marginal opening and dissolve your cement. So the crown, the factors of retention resistance get affected because of your marginal opening. So your cement should be that much better to able to compensate for your post cementation marginal opening. There is no cement created so far that does not have some amount of marginal opening, be it even a resin cement. Resin cements are the newer age cements, all right? So they have been introduced very recently, but even those cements have some amount of marginal opening. So do anybody have an idea what is the type of cement that gives you the smallest post cementation margin opening? Does anybody know about this? Is it the post polycarboxylate, the zinc phosphate, the resin, or the GIC? What do you think has the smallest post cementation marginal opening? Before I answer this question, all I want you to know about is, and I want you to have a snap of this or have note this down. Okay, I made a small chart with regards to a comparison with regards to your GIC cement, your resin modified GIC cement, your self adhesive resin cement, and your traditional resin cement. Okay, so when I say GIC, this is your glass ionomer. RMGIC is your resin modified glass ionomer cement. Okay, your self-adhesive resin and traditional resin are also resin cements. In self-adhesive, okay, you do not have to apply bonding agent. Okay, so it comes within the tube itself. But traditional resin, you have to etch, bond, and then apply the cement. For your self-adhesive, as the word says, self-adhesive, it will stick on its own. No bonding agent is required. You just have to etch it and apply the cement. Okay. So this is a small comparison. Questions in NEET can be asked with regards to which of these cement has a better compressive strength, which has a better flexural strength, which has higher fluoride content, which is aesthetic, which is sensitivity risk, or which have best adhesive strength. As you can see here, your traditional and your self-adhesive resin cements are the best with regards to your adhesive, aesthetics, flexural, and compressive strength. Okay, but they are very poor with regards to your sensitivity risk and your fluoride content. So what we did was, or what the manufacturers did was, they started joining the good properties of GIC. As you can see, GIC has a very high fluoride content and it has a very low sensitivity risk. So what the manufacturers did was started mixing a resin cement with a GIC, and that is how resin modified GIC was created. As you can see, your resin modified GIC has a moderate strength, very high fluoride content, low sensitivity risk, and good. So it is the best of both worlds. It has good strength as well as it has good since it has good fluoride content and it's a very low sensitivity risk. So that is your so you should see what question you're asked in your NEET with regards to your compressive strength, your flexural, or your sensitivity risk. If they say, now this could also be a clinical scenario based question. If they say the patient has a very high caries index, in which the patient has a lot of caries affected tooth in his mouth, which would be your preferred choice for cement? In such a scenario, resin modified GIC should be your best option. If they say which is the best compressive strength directly, it's a direct question, then your answer is traditional resin cement. So you have to be very careful with regards to what you're being asked, which property you are being asked, and which are cements that you have to play with. Okay, so be very careful when you're answering questions in regards to properties and the types of cements. Coming back to the previous question, I see a lot of answers with regards to B, A, D, and C, right? One of you have got it right. The answer is B, that is your zinc phosphate cement. Okay. Even your GIC produces some amount of marginal opening. So if the order is asked, okay, your zinc phosphate is 1. That is the least amount of post cementation margin opening. Your resin cement is second. Your glass ionomer is third, and your polycarboxylate is fourth. That is the order with regards to the cements which produce the least amount of marginal openings. Your phosphate produces the least. Next comes the resin, third GIC, fourth polycarboxylate. Don't always think that resin is good, right? Resin is good with regards to certain aspects. GIC is good with regards to certain aspects, but with regards to post cementation margin opening, it's your zinc phosphate, which always comes first. All right. I hope it's clear. Any doubts, you can just type it down and I'll come back to it as fast as possible. All right. So this is regards to your cements. Coming to the next question, an all porcelain crown will most likely fracture when? Is it A, used in edge-to-edge occlusion? B, when it's fabricated for a mandibular incisor? C, it's allowed to contact the opposing teeth in centric occlusion? Or D, is subject to tensile forces by an opposing teeth? All right. So as we all discussed, we know the different types of crowns. It is not said zirconia particularly. It is said all porcelain crown, which means it could be an all ceramic. It could be any type of an all ceramic crown. So when do they most likely fracture? This happens ideally, okay, when it is used in an edge to edge occlusion. So like we discussed earlier, they wear off quite easily. So what happens is, I see an option D as a scenario, but option D is the tensile force by opposing to, like we discussed earlier. Opposing teeth are still more weaker regards to your than your all porcelain crowns. Your opposing crowns still are more stronger if the preparation is done well. Okay, so ideally speaking, it is when an edge-to-edge occlusion they fracture more. This also is a correct answer. Okay, but the question is most likely. So this is your first option. As we all know, all porcelain crowns, the tensile strength is very less, but it will take some time for the opposing tooth to fracture an entire crown. If this option is not there, the first option is not there, then this is an ideal number two. like a backup option. But whenever it's given an edge to edge occlusion, 95% of the times your all porcelain crown will wear each other off, and within a matter of a few weeks, it will fracture. Right? This is how they are supposed to contact. They're supposed to be in centric occlusion. They're not supposed to be in edge to edge occlusion. Also, D, as we said, all porcelain crowns, compressive stresses, they withstand very well. Tensile stresses, they don't withstand that much. But for this to occur, to fracture a crown, will take a minimum of at least 1 to 2 years, because your natural tooth cannot wear off your porcelain crown that much easily. Right? I hope it's clear. Please do not confuse yourself with different properties or the different types of crowns. Whenever questions like these appear, the whole point of having certain options is to confuse you. That is what NEET gets a lot of joy from. So be very careful when you're answering such questions. Coming to the next question. Which of the following teeth is the least desirable to use as an abutment for an FPD? Is it tooth with pulpal involvement, tooth with minimal coronal structure, tooth that is rotated and tipped out of line, and tooth with short tapered root with a long clinical crown? Now, all these options, some way or the other, are trying to trick you or to trip you away. All right, that is the basic point of it. So, what you have to understand, anybody, what do you think? What do you think the option is? Is it A, B, C, or D? What do you think is the least desirable to use as an abutment for an FPD? So what you have to understand is tooth with pulpal involvement is a undesirable structure. Tooth with minimal coronal structure is also undesirable. Tooth which is rotated is also undesirable, or tooth with short tapered root with a long clinical crown, right? So the question they're asking is the least. We all know all four are undesirable, right, to use, but can we still make it better? Okay, so before I answer this question, in case I have a tooth with a pulpal involvement, okay, what do I do for a pulpally involved tooth? Is I do something called an RCT. So once I do an RCT, if the tooth has a very good tooth structure remaining, right, I can always go ahead and treat the tooth with an RCT and give a crown. If it does not have enough coronal structure, I do something called a post and a core. Okay, so not enough tooth structure remaining, I do a post. So this is an example of a post. We prepare something after we finish root canal, we do something called a post space preparation, and then we put the post inside, and then we build the core. This is the core. Now I have enough tooth structure on which I can place a crown completely. So whenever pulpally involved, it is undesirable. I do a root canal, not enough coronal structure. I do post and core like this, and I place a crown. If the tooth is rotated, I can make it straighter, and still I can work with it. Right. So coming back, I see many of you have got it right. Very good, perfect. All of you have got it right. Right. So the answer should be a short tapered root with a long clinical crown. This I'm treating with RCT. This I'm treating with post core, rotated and tipped of line. I can also do an intentional root canal, and I can make it straighter to use as an abutment. But tooth with a short taper, I have a long crown, but I have a short root. So you can understand how much the lever mechanism is going to play. This will, anything you cement here will cause the removal of the tooth. So this, as we all know, the crown root ratio, that is what you have to understand to answer questions like this. So very good. I see all of you have got it correct. Perfect. Very good. That is how you understand questions like this. I'm very happy that all of you have got this correct. Now coming to the next question. Patient is unhappy with the aesthetics of an anterior PFM crown, complaining that it looks too opaque in the incisal third. The reason for this is most likely the ceramist used an incorrect opaque porcelain shade, Inadequate vacuum was created during the process of porcelain firing. We didn't mask the metal well with the opaque, because of which there is a see-through and it looks very opaque, or the tooth was prepared in a single facial plane. Which among this do you think is the likely answer with regards to the patient being unhappy of the tooth preparation, of the tooth which has been cemented? Anybody? So ideally, what we do is we do a preparation in three different planes. Okay, I'm going to explain to you first from the preparation aspect and then from the ceramist point of view. Okay, so what we do is, suppose you're doing a PFM preparation or an all ceramic. This is your flat end taper burr. Flat end taper burr helps you giving a nice shoulder finish line. Okay, so that is what your PFM requires with regards to your uh, finish line with regards to your labial structure, the buccal structure. So what we're doing is we prepare it in the gingival third, we prepare it in the middle third, and then we prepare it in the incisal third. Okay. So whenever we're doing a preparation, we have to make sure we do it in three different levels. This is first, this is second, and this is third. So what happens is that if we you can see the thickness, right? I have so much thickness here. I've reduced thickness here and have the minimal thickness over here. If you're going to keep a very thick incisal edge, all right, so you can see the amount of thickness, how it's varied. This much here, the middle third is this much, the gingival third is this much. If you're going to keep a very thick incisal third, the ceramist is also going to dump that much amount of ceramic here in this aspect. Now, if you're going to see your own teeth, all right, when you see your own teeth, you see a small incisal blue color translucency appearance over here, followed by your white color of your tooth structure. This becomes more whiter, it is more faint blue, this becomes white, and as it goes, it becomes very much dark white. Okay, and then here is your slightly yellowish with respect to your stains or your gingival fluid, especially seeping out. So this is what you're trying to reciprocate in your patient's mouth. So if you create a thick surface here within the incisal edge, the ceramist will also create a thick opaque surface, and this is going to look very artificial. Okay, so you have to understand that the preparation has to be in three planes and the incisal edge has to be thin. So this is what I'm talking about when I'm talking about a thin preparation. As you can see over here, it has to be faint edge. So you can see this part, this is what you're trying to replicate over here. You can see this part is being replicated over here. And the same to the gingival third is being replicated. So now the ceramist can also make a crown which looks as similar to the natural tooth over here and can be easily cemented, keeping in mind the translucency at the incisal edge. So this is what you have to understand with regards to your tooth preparation. I see all of you have got it right. Very good. Answer is D. The tooth was prepared in a single facial plane. If we had done it in three different planes, this problem would not have arisen. Another option, if you do not have D, then the answer is C. This is your second preferable option. All right. So what happens is that if your ceramist does not put an opaque, so this is with regards to the types of preparation. You have to have an even preparation all across. All this is an under preparation. So under preparation has to be avoided. Also, there are some critical questions with regards to the shade selection. We have something called as the cue ball effect. Okay. So what I want all of you to know is that there could be a question why the cue ball effect has arisen. Okay. So what I want you to know is that it arises when you choose the same shade for all the teeth and for all the levels of your tooth. So what I mean by all the levels is that your tooth, if you see in your own tooth does not have the same white color everywhere. Okay, it has a different degree of whiteness everywhere. So you divide the tooth into three parts. You select probably A1 shade here, you select A2 shade here, and you select A3. So as you go more cervically, you make it more brownish. But if you select the same shade for all the teeth in all the three different levels, then it gives rise to something called as the cue ball effect. Cue ball is the same ball which is used in your snooker, right? When we all play snooker. So ideally, if you choose different shades, like you can see here, different levels of white for different shades, and you match it perfectly, the cue ball effect does not arise. So this is what is regards to the shade matching, which you all have to be careful about. Now, coming to the next question, I hope there are no doubts so far. Which of the following is the single most important predictor of clinical success of a casted post and core? Is it the amount of remaining coronal tooth structure? Is it the post length, the post diameter, or the positive horizontal stop? Okay. So ideally speaking, there are different levels with regards to the clinical success of a casted. Now, keep in mind they're asking about a casted post and core and not about a normal post core. A post core, as you know, has different classifications. Okay, so you should first know what they're actually asking you about, whether a casted post or they're asking you about a prefabricated post core or they're asking you about a cement post core system. So uh, we first understand what type of post core they are dealing with. Okay, so the first question arises is you could also be given photos like these 1, 2, and 3. Okay, and they ask you on which of the following scenarios a post core is actually possible. Okay, so how do you answer questions related to your post and core? So, like I told you, what we do in a post core is we first finish root canal, then we remove 1/3 of the gutta percha of the root canal, what we have done, and we place that is called as a post space, and then we place a post inside that. All right. So, what you have to understand is the amount of remaining tooth structure is what decides the post core system. So now I have here one wall missing. In this, I can just do an amalgam filling or a composite filling or a GIC and finish it off. Okay, so this does not require a post core. In this scenario, I have three walls missing. In this scenario, I had only one wall missing. Here I have three walls missing. This needs to go for a post core. The same way, I have three walls missing here, or at least I have two walls missing over here. And this also needs to go for a post core because my crown needs a good structure to sit on. So when you're given clinical questions like this, is a post core possible in this particular scenario? Which scenario is it possible? Do not blindly say yes for everything. See how many walls are missing. If it is less than one wall, you do not require a post core. Okay, if there are more than one wall missing, like there are three walls missing here, there are two walls or about 2 to 3 walls missing here, that requires a post core. Okay, I've made a small chart. Either take a photo or just keep this in mind or note it down with regards to where you require a post core. So whenever you have one or two walls remaining, one we will not consider in this scenario, two walls remaining, we use a prefabricated post core. When we have two or three walls remaining, I do not require a post core. I just do a composite core buildup, or I do amalgam core buildup, or GIC restorative. All of them can be used. If no wall remains in such a scenario, we do a cast post and core. So you have to know which scenario I'm going to do a cast post and core, and which scenario I'm going to do a prefabricated, and which scenario I do not require post core at all. Okay, so this is how you decide with regards to when and where a post core treatment is required. Coming back to the earlier question, which of the following requires clinical success of a casted post and core? Is it the length, diameter, or the horizontal stop? I would still say the amount of remaining coronal tooth structure is so much more important. Okay, you want me to repeat the image? Okay, so ideally, whenever you can see over here, we have one wall missing only, so we don't do a post core. We have three walls missing here. We have done a post core. Here we have about two walls missing, which is why we are also going to do a post core treatment. Okay, so that is how we are going to deal with the amount of structure remaining and the amount what treatment required. This requires a GIC or composite buildup. This requires a prefabricated post. This requires a cast post and core. Okay, that is how, this is what have been spoken about in this particular slide. This is a basic guide for you to decide the type of post core that is required. So coming back to the question, post length is again important. It is the second most important area, how much I'm going to get play with. But the first will always be the amount of remaining coronal tooth structure that is there, and that is what's going to determine. Because of this, I get something called as the ferrule effect. Okay, ferrule effect is nothing but the amount of remaining tooth structure that is there, which is going to hold on to my post and help improve the retention and resistance of the post itself. Okay, so any question like this, do not get confused. You should know what type of post you have to choose, where and when a post core is indicated. All right, so coming to the next question, the characteristic of tooth preparation that tends to prevent a seated restoration from tipping or rotating. The key, the question is tipping or rotating around the preparation directed in apical oblique direction is retention, resistance, Antes law, or crown root ratio. Okay, so what I want you to understand is first the difference between a retention and a resistance. Okay, retention is in the absence of occlusal forces. Resistance is in the presence of occlusal forces. So the key is everything. If you just know the definition of all of this, you will be able to clearly answer all of them. All right, so retention is the ability of your crown to withstand dislodgement in the absence of occlusal forces. Resistance is the same property in the presence of occlusal forces. So the answer would be A, that is your resistance. Okay, Antes law, again we all know, crown root ratio we all know, that does not play a bigger role with regards to the tipping or rotating of your crown with regards to when your occlusal forces are directed on that. Okay, so this is how it basically we're talking about. So we know how the tensile and shear stresses work. This is a graph which you should all know, because many questions are asked based upon this graph on how the tensile and shear stress forces are proportional to each other. All right, so also the length is very important, your taper is very much more important, and the retention resistance form. This is with regards to the principles. I'll be dealing with this slightly more detail in my future classes as well. Coming to the next question, the ideal treatment of choice for a tilted teeth is extraction, telescopic crowns, full veneer crowns, or orthodontics. Okay, so you have to understand tilted teeth are the teeth which are not in the same arch. Okay, so we try our best to prevent extraction. Invasive procedures are indicated only when we have no other choice left. So we are left with something called telescopic, full veneer, and orthodontics. Before I answer this, you can let me know what you think is the correct answer. But before I answer this, I'm just going to show you a small thing about FPD. So this is how an ideal tooth structure mainly is. So these are nice and straight along the long axis. I do the preparation. I place the crown or the bridge in that area. I'm done with my 3 unit. But what happens is that if they are tilted in one direction, the crown will get locked. So what we do with telescopic crowns is that we push a crown into the prepared tooth, make it slightly more straighter so that the path of insertion remains straight and it's not curved and gets locked into it. That is your telescopic crown. Okay, so that is with respect to telescopic crown. Full veneer is what I just showed you, and these orthodontics. We try to do a more conservative. So your first principle of tooth preparation is preservation of tooth structure. So ideally, telescopic would be your second option. Your first option should be always D, that is through orthodontics. If you feel orthodontics is not going to work, Then we go for B, that is your telescopic crowns. That is your treatment choice with regards to, I see somebody got it correct as well. Very good. D, orthodontics is your ideal treatment choice with regards to your tilted teeth which are not in the arch. We'll just finish this off quickly. Coming to the next question. A patient complains of sensitivity a few days after cementation of a fixed partial denture with polycarboxylate cement. What is the most likely cause of it? Is it irritation from the cement? Is it a loose retainer? Is it because of premature occlusion or because of an open margin? What do you think, all of you, is the cause of this? What to understand is a polycarboxylate is has a slight amount of acid, that's your polycarboxylic acid, so it is capable of causing some amount of irritation within your periodontium, right? But sensitivity as an issue, why do you think the patient has sensitivity with regards to an FPD? So irritation from the cement is still an option because like I said, polycarbolic acid is present. A loose retainer will not cause your sensitivity as such. It will just cause dislodgement. The crown will just come out. So this is not a correct answer. A premature occlusion is also could be a reason with regards to sensitivity occurring, and open margin. So you gave a subgingival preparation, and because of which it is the cement has leached inside, and that could also be a cause. But what happens ideally with regards to an FPD is that the first major causes of sensitivity are not your open margins. This is very common. What we do is our shoulder finish line. So we have, there's a slight misconception that I can see many answers with regards to D as well. The misconception is that when we do a tooth preparation, we keep a shoulder finish line and the cement seeps inside. This will not still cause sensitivity to the patient. Okay. What happens ideally is because of a premature occlusion. Our crowns, our shoulder finish line, our crown will sit on the finish line itself. It will not prevent the cement from seeping into it. An open margin has to be as big as 5 to 10 millimeters to cause sensitivity to the patient. Okay. Irritation should be your second preferable option. Third is your open margin. Occurrence of that is very, very rare. So if you're asked questions about this, do not think that open margin is what's causing this. Okay, it's most of the times an occlusion effect. So you take an articulating paper, reduce the high points, and that becomes so much more better for the patient after we have reduced the eccentric relation with regards to using the high points. Open margin, very rare. Irritation from cement, especially if you're using your polycarboxylate, your eugenol, or even GIC to an extent. Okay, it does cause some amount of irritation, but GIC has very less sensitivity risk, so that happening is very rare. So do not get confused with regards to the cement that is being asked or the likely hood of an open margin. All right. So I hope it's been clear for everybody so far. I just want to know if everybody has any doubts. Just understand we're all doing this because it's just a question of training, right? So with help of Crownedge, you're just getting trained to answer all these questions with regards to your NEET. So keep studying.